Everyone, welcome to the 2017 Harmony webinar series. I'm pleased today to be joined with Dr. Letitia Bader with Denver Women's Recovery, who's going to be speaking on women and weed, trends for the 21st century. I just want to qualify that I know that this original webinar was scheduled to start at 12:15. We are recording it, and it will be available for those who want to view it later. If people are jumping on, we'll make sure that they get access to the information after the webinar. For those of you that are new to Harmony Foundation, Harmony is nestled on a 43-acre campus in the Rocky Mountains just outside of Estes Park, Colorado. Our Colorado residential rehab offers comprehensive treatment for adults and their family members. We have a continuum of care that begins at detox and goes through transitional care. So who is Harmony Foundation? Harmony believes that long-term recovery from alcohol and other drugs is possible. And how do we do this? We believe that we're a place between two worlds. Our location in the Rockies provides a safe and quiet respite from the pain of addiction. With 47 years of treating addiction, we have fostered a generation of long-term recovery who supports our clients and families for a lifetime. Harmony's staff at all levels of the organization work together to create a community of recovery support that is long-lasting. We are a 70-bed residential treatment center. We offer a full continuum of care beginning at detox through transitional living. We're located at the base of Rocky Mountain National Park in Estes Park, and we offer evidence-based 12-step programming that is gender responsive. For those of you that are interested in learning more about Harmony, we invite you to visit us at harmonyfoundationinc.com, or if you or someone you know needs treatment right away, feel free to call our admissions staff at 866-686-7867. Just a couple of housekeeping items before we kick off our webinar. Please be sure to complete the online evaluation form at the conclusion of the webinar. If you registered for this, you will receive an email survey that's about an hour after the webinar completes. If you don't see that email, please let me know. You can email me at gthorne@harmonyfoundationinc.com. You will also receive a certificate of completion. This program is approved for 1 NADAC hour. If you don't receive the certificate by this Friday, please contact me and we'll make sure that you get one. I want to take a moment to say thank you to Denver Women's Recovery for partnering with us on this webinar. If you're interested in learning more about Denver Women's Recovery, please visit www.denverwomensrecovery.com, or you can call them at 888-233-1553. So let's go ahead and introduce Dr. Bader. Dr. Bader has worked in the field of mental health and addiction for more than 16 years. She graduated from the University of North Texas in 2007 with a PhD in counseling psychology and a specialization in sports psychology, and completed her postdoctoral fellowship in chemical dependency at the University of Oklahoma Health Sciences Center. She's a licensed psychologist and licensed addiction counselor. In addition, she is also a certified mental performance consultant. Her areas of expertise include cognitive behavioral therapy, dialectic behavioral therapy, acceptance commitment therapy, trauma-focused CBT, trauma recovery protocol, biofeedback, and the treatment of dually diagnosed clients. Dr. Bader recently joined Denver Women's Recovery in October 2017 as clinical director, and she's here today to talk to us about women and weed. So at this time, I'm going to go ahead and transition the presentation over to Dr. Bader.
Good afternoon. So we'll get to it. Thank you so much for the introduction and just the support on the topic. I know for many of us, it's a little near and dear to our hearts. It literally might be down the street at your local dispensary. So that's what I'm going to take the time to do today. I am a clinical director here at DWR, and I'll shorten it, mostly because I like acronyms. And I'm so, so proud to be here. My journey got me here knowing that DWR is the only women's IOP in the Denver metro area, and we're only a handful in the state. So that gender responsive treatment programming is so near and dear to our heart that that's what we are, an IOP here in town. So that's us. I love the clinically savvy because we try to be savvy every day. And we'll go ahead. This is my special thanks. It's like a shout out to Holly Wilson and all the DWR staff, to Ben Court, my weed mentor, my guru that I daily get education from Dr. Martin and Dr. Klee and Barry Platter, and they are kicking in the doors to try to understand women and we and testifying and preaching everywhere. So thank you so much for all of your advocacy as well as your education. This is for everyone who needs to know that it's satisfied as CEU. And most of the time I tell you, I hope I educate you. If anything, I hope at least I entertain you. But I will do my caveat is the things that I'm going to not cover is casual use. So if you got on here and you are pro-cannabis and you want to have a conversation afterwards about how casual use is in the state of Colorado, that's awesome. Email me later. Today is for the clinicians, the helpers and healers that really need a better conversation to have with women about cannabis, marijuana, what it's doing to our bodies and our lives. So that's what we're doing. So I tell you that because I want you to know your intentions. And so I'll tell you mine. That's what we do here, is to get a little vulnerable and be transparent. So I arrived in the state as they were campaigning for legalization. And knowing a little bit of what I knew and not knowing enough, I was still screaming, please, dear God, don't do that, don't do that. Oh my goodness, oh my goodness. And so I'd probably be considered part of the Reefer Madness crew, and I will tell you why. So to some, I can kind of come off as a teetotaler who pushes nothing but abstinence and might be judgmental of casual users. I consider this kind of a job hazard. Being in the treatment field, I don't see the women who use recreationally or the 1970s high school reunion ladies that come into Denver for the weekend and just try out concentrates, although I was on a flight with her. And they lost their friend for most of the weekend for her first time using concentrates. I see the women who smoke from morning to night that have a 2-year-old and that cannot control their use. They're running from pressures of motherhood, women's issues, and have few places to try and find healing. And I know that this population is small, and I speak about it maybe like it's the whole world because it is my world. It's powerful, and it encourages me to share knowledge, empowerment, and wellness. I want people to be educated consumers of cannabis. I want to hold the industry accountable, and I want to provide resources to helpers and healers in the field. And so that's my good to know. And we started there with our campaigns, if you know anything about the campaigns that we're trying to fund here in Colorado. And we're going to what's next. So these are the campaigns that are putting out a message to our youth, trying to put a message out to our community. And I'm just going to give you my little message. You never knew this, but today you're going to get a little bit of information on like how to take a selfie and why your selfies aren't going viral. It's called the rules of attraction, and it's the rule of a third. And so I actually learned this in photography as I was growing up, is that if you take the subject matter and you position it off to the side just a little bit so that it can kind of cut into thirds and end up a little off to the side, not front and center of your subject matter, it's actually more attractive. So that's what I'm telling you is happening to us as consumers and residents of Colorado. The industry, and I will call it that from heretofore, is placing their message in that 1/3 of our perspective. They're moving it from front and center, and they're taking it off to the side. They're taking our research, taking the research that's been given by scientists as we're trying to pump it out as fast as we can to keep up with the potency and the products, and they're just watering it down enough, just enough so that it gets out of that front and center kind of picture. And I believe that this is what's happening. If the message is about taxes, if the message is about the miraculous aspects of marijuana, or that it's safer than opiates and the billboards start going up, is just to let you know that we are in the middle of a campaign and it is changing our hearts and minds. And so that's what we're just going to talk about today, is to talk a little bit about the message, a lot of bit about science, and then specifically, I'm going to kind of go through each aspect and tell you what's different for women as it starts to come up. My good friend says that I got my education in ivory towers while he got his in rehab and jail. And so I usually like to start my research with a Google search and the rooster. And so I just Googled, should I smoke weed? And amazingly enough, I should. And I should smoke weed for almost everything. It can increase my energy. It helps me with sleep. It makes me more productive. And for every one of these bullet points that you see, and this was from the herb, so it was not a peer-reviewed article, but I went through and I had to go through 27 pro-cannabis links in my Google search to actually get to one of my first scientific articles. And that was even produced by a newspaper, and they had replicated a study or reported on a study. It can do anything. That's what we're being told. It can, I love cannabis smokers. They're happy, they're rich, it helps lose weight. It's almost like an elixir back in the day. And it does mostly everything. So after Googling, oh, by the way, this is the must-have holiday item, just to let you know. This is some high fashion from cannabis. It is, and that Reefer Madness, they kind of joke, is that they did a little head nod to all the Reefer Madness on the back. It's glamorous. That's what's out there. We are in the midst, it says, of the biggest cultural shift. And cannabis is becoming part of our everyday lives. It's coming in fashion. It's coming in conversation. It's there. So I Googled again, maybe getting a little bit more specific, and I Googled women and weed. And knowing that I am not their target audience. So when you're targeting, when marketing is targeting audiences, it's to try to get new users. It's hoping to increase the use of new users so that they become regular users. And it's also there to increase the frequency of regular users in order to become higher consuming regular users, almost on the daily, if not starting to really work on tolerance and volume. If anybody is as old as I am, or even maybe a little bit younger, is this campaign should sound familiar. Get new users, make new users, regular users, and get regular users to use more. And I should use weed. This is why weed is made for women. And we went through, and you can probably already hear my bias, but I will tell you in the next couple clicks, it promised me companionship, connection, increased health and joy, or increased health and joy, like joy. And if I was an average person going through, kind of looking, I would be hooked. So I clicked a little bit more and got into the article. And again, the promises started to show. It will relieve symptoms of anxiety, and it will relieve stress. It can help with sex life. The weight maintenance, especially as our New Year's resolutions start to come up, intrigued me as always. But I want you to start to get to notice what happens is that a pretty potent message kind of gets embedded in, and we just talk about it and oh, yay. We kind of call, if you were a drinker, you would be a cheap date. I think back in the day, they would call it that. And the industry is already letting us know that women get high faster than men. And we're going to kind of talk about aspects of what that means for us as women for addiction, tolerance, and treatment. Again, sleep is promised. Anything related to cramps, PMS, PMDD, it is literally, I like to read this. It says that it can treat almost anything, and it can prevent or treat cancer. It literally says THC has been shown to kill cancer cells and inhibit tumor growth. This marketing campaign that gets us, it gets about the age bracket for scares for breast cancer. It gets into the population for women that are right now overworked, overstressed, doing our absolute best to balance these kind of superwoman lifestyles and still make a pretty good selfie on Facebook. So it gets right at the heart of what concerns women the most. Number 8, especially my physicians out there, this is the part I think that's the most dangerous, is the message that's going out for pregnancy and the benign aspects that the industry is marketing to us. And then there was that joy. Number 9, total joy. So when we get into the women get high faster than men, the literature, the industry says, keep in mind, however, that women build up a faster tolerance to marijuana overall. And we're going to get into the absolute science of that because that is true. Just to let you know, again, PMS, if anybody's struggling right now, your local dispensary does a little bit better even than your Advils and your ibuprofens. Don't worry. We have bloating, migraines, cramping, anything can all be alleviated by smoking weed. So it is going to be the medicinal wave of the future. And that part where it does the all is the message that's starting to get across louder than science. This part, it was the only nod to it being a controversial subject, and that was all that was mentioned. And so any of the risks that were associated with either pregnancy or breastfeeding, how much cannabis has easy access to a child and the mother was not mentioned as well. And this is my Wonder Woman shout out to all my ladies out there. If anything, we've got so much going on in our personal lives, a little bit of weed gives us that permission to stop, relax, and enjoy life. That's what's being promoted to us. So I'll give you the picture that was the most attractive on there. And then I did a little flashback. And I found in my day, when I picked up a magazine, and I know that makes me sound old already, but when I actually picked up a Slick magazine that my mom used to buy, I saw the same thing and wondered. I actually asked my mother why she didn't smoke. My grandfather smoked, and that'll kind of come up later. And I said, Mom, look, career woman, here we go. So in the cannabis industry, that's the message that's being sold to women, is we can go a long way. We can break the glass ceiling, they call it, and put a bong in our hand and take over the world. I went back a little bit further just to see if any of these campaigns had been introduced to women and where we went from then. And of course it had. So the prescriptions that were given to us early on can get us back up cooking for our family. And now we can cope. I bring your attention to the part that it says a daytime sedative for everyday situational stress. This is what weed is being marketed as. This kind of catch-all, do-all drug that can cure, treat, and alleviate many, many, many concerns that are specific to women. So I noticed when I had to read, this is a fun fact for y'all, when I actually had to read the side effects, it was more potent to me. And I know we hear Pfizer give us commercials on the internet or on the television that has all these side effects, like it only treats one thing, and then there's like 22 side effects for what we're going through. And hearing them has been one thing, but when I would go back through and actually read the side effects, it just seemed more, it hit home a little bit harder. So I give you for that for yourself, as well as maybe for your client caseload or your patients, is having them read some of the side effects or read some of the science, if that's in their literacy range, might be a wonderful way to have an intervention, is to really get them down into websites, into articles, and having to read it for themselves. Just a side thought. If you're new, that's the whole part about a webinar, so everybody nod your head because I can't see you. We'll go grab anybody that's new into this field, and just to let them know that there are multiple types of cannabis out there. We are racing to keep up with the industry of all the new things that are coming out daily as we speak. But this is most of the types of cannabis that you can get out there. We have the plant-based that we've seen for many years, from Exodus, from Genesis on. Our concentrates, which you can see there, are that high potency extraction from the plant. Edibles, oils. Edibles are actually the top selling product for people that are using it for cancer treatment or nausea. They actually don't smoke as much. They use edibles and to dose themselves that way. The oils, the topicals, and the tinctures. And so that's your Mary Janes and your arthritis relief are some of the other ones. And we'll talk about how topicals are promoted to women more so than men. I put this slide on there. A good friend, Ben Court, did it. He put two slides together because when we were on the road speaking, is that you couldn't quite get the shock value that you needed from the two different slides. And so we had put up the national numbers in one slide and then put Colorado numbers on a different slide. And it didn't drive it home. So when he put them both together, I grabbed it. So this is where we're at. And this is just plant-based cannabis within the last couple of years. So we have that 1960s, and that's where the lines start to deviate. So the THC, we're going to talk about, that's the part of the plant that gets us high, that has the psychoactive part. And then the non-psychoactive part, CBD, is the red line. And so I just slow down now, and most of you all in the treatment helping field know that this is where we're at for potency, is that the plant-based product that we've had has gone up significantly. As we started to get it kind of in the 80s, 90s, there were still gardeners making this plant. But by the time that we legalized, we actually have scientists, and they've moved from gardening to just straight manufacturing. And they're taking a plant and making it the most robust, the most concentrated plant that they can get. And right now, our plant bases here in Colorado are up to that 45%. We didn't put the concentrates on here because it would blow the chart completely up. What we've seen being tested so far is at least 99% pure THC. My soapbox when I get onto it next is the difference of, if we're going to have a conversation, let's have a conversation. And let's have a conversation as educated consumers. And so if we're going to have a conversation, let's do it. THC is not CBD. And so when we're talking medicinal marijuana, when we go on talks outside of the state, people talk about that and it's like, oh, you're medical marijuana. And I said, can you just take the word medical out? And one of the gentlemen at the conference room table was like, why? Like, it's got to be different. I said, it's not different. It's just cheaper. When you have a red card in the state, it's the exact same marijuana. It's just taxed at a different rate. So the THC is what people are using to get high, and the CBD is where we're starting to find a lot of more interesting potential and more interesting medicinal benefits. I was on my podcast this morning for the cannabis, and they're already doing studies at CSU that are taking CBD and using it for animal studies, for arthritis, for any kind of seizure disorder in dogs. I'm out of their way. Let me get out of their way. Because mine is that if we can learn from a plant and take the part of it that does not include getting high and benefit from it, I'm in. So that's where that teetotaler part sounds a little paradoxical. But I will tell you that there are probably going to be some amazing things that we learn from CBD. And if not directly using CBD, we'll understand the principles of what it can do and utilize that as well in our pharmaceutical companies. So if you catch me on the street, or see me anywhere, if you want to have a conversation, I'm totally down for that. Let's just do it differently. If we're going to talk THC, let's talk it. And if we're going to talk CBD, let's talk that. So in my mind, there's not medical marijuana. We can use marijuana or cannabis in a medical fashion if you'd like to do it that way. And my soapbox is, I've never had a therapist tell me that alcohol can be used medicinally. It can be used to relax. But that stays a drug no matter no matter what it is. Alcohol stays a drug and an intoxicant, and we just use it in a different fashion. So even as we were using it to lower our heart rates, or even our chocolates, right, is that chocolate has never become medicine, but we can try to use it in a medicinal fashion. So that's the conversation that I have. As we get into that THC, CBD, just to let you know, it's being marketed straight to women. I put a couple of the top products up there for this year, and this is where I would love to see you in person. I hope somebody has giggled by now, because there really is a weed tampon. Bliss is our lubricant that is straight to women. It's packaged that way. It's instructed in that fashion. It's a lot more about pleasure for her. And Whoopi Goldberg and Maya have a full line. So there's rubs and soaks and salves, and that is all mostly for the treatment of PMS or any kind of aches and pains from that. My favorite, because I'm a coffee drinker and people know that, is there's Pop-Tarts, cherry flavor, as you can see up at the top. And the complete, I believe it's alliteration that I get to say to you now is the Peter Piper Pecker Puffer. And I left the full description on there just if anybody needed a giggle before the holidays. It says, anything that makes the life of a lady a little easier is worthwhile. Not only does this sex toy bring you pleasure, but it also allows you to take a puff or two after you get yourself off. It says so right on the box. Smoke it and then poke it. These are the products that are out there for women. Still exploiting well, I'll just leave it at that. I hope somebody's giggling by now. If somebody puts in a question about how to use that, I will not answer that. Just let you know, Gina. This is where we're at. And so the industry is marketing to us specifically, and these are the products that are starting to come out specifically for women. I'm going to go back to the facts, and this is what I want everybody to know. The facts haven't changed. Research is starting to support these. It already has. The research that has come from Europe confirms what we know. Here in the United States, Old Misses are actually right now our only still official grower. And when we start to talk about the studies that talk about addictive principles and some of the outcome studies that we have, remember that this is only at a plant-based percent of 16% potency. And so mostly everything that we have on the streets here in Colorado has blown well past that. At times, medicinal use of marijuana, when they do a lower THC, this is still where the studies would come true. Some of the cancer patients and individuals that are using it more on a daily basis for chronic pain are using some of the lower THCs and trying to get a higher CBD. So that 1-to-1 ratio would stop the psychoactive effects and kind of balance that out, is that if people are using it more for relief that way to get high. But the studies go on this at most 16% potency for plant-based materials, and we still know that these statistics are true. So I say that to the future, as I can only imagine once we start being able to test potencies that we are seeing here in Colorado up into 40%, 45% for plant-based, and then up to 99% concentrates. I'm going to go on record to say that I think these numbers will change significantly. But right now we know it is still addictive. So if there's a myth out there that it's not, I would like you to know that that is still a fact. So 1 in 6 adolescents who try it will become addicted. 1 in 10 adults that try will become addicted as well. And right now what we know, mostly I think to the Truth campaign and to the changing behaviors of the adult population, is that teens are actually more likely to be smoking marijuana than they are to be smoking tobacco. Tobacco has sort of finally gotten its accurate rap. I don't say bad rap. I said it's accurate representation of what that drug does to us as a society and what it does to our bodies. And so the children of our generation know that that's not something that they would like to put into their bodies because they actually know the effects of it. And the campaign, the Truth campaign, is actually letting them know, and has been for a while. So a lot of those promises that just happened on herb.com in my Google search or Leafy is they are starting not to be true. So what we know is that adult users are actually more anxious, more psychotic, less alert, more disorganized, have dry mouth, more hypertensive, and actually want to use more. And that's that tolerance part. So a lot of the claims just went out the window. This one is for the people that really like it, print it out. And this is a 1 or 2 page article that you can get and leave out in your waiting rooms or leave out in your treatment centers. And it's from improvinghealthcolorado.org. And it literally states what we already know to be fact. When we smoke, it increases heart rate, blood pressure, that excessive sedation. So that's one of the things I gave it to an orthopedic surgeon, knowing that many of his athletes were smoking and not getting tested, is that I told him to start to consider this before they would go in for knee surgeries or elective surgeries. Not necessarily that you can avoid anything if it's an emergency surgery, but if he was putting his athletes in front of, or putting his athletes on his schedule for surgery, is to make sure to start drug testing them about 2 weeks, if not before, to start to get levels of them. And he kind of looked at me and I said, it makes your life completely different there in the surgery room. And same for anesthesiologists to know that if marijuana is on board, it could literally change some of the outcomes that we see in the surgical rooms. We know this one, it's starting to go around as fact, that motor coordination, distorted perception, I like chronic smoke use increases the risk of, and that sounds really fancy. And so I usually water that down to like a party girl cough. We had an athlete that had one of those coughs, and it usually showed up in the 3rd or 4th quarter a little bit more. And we knew when he was sober because he could get a good deep breath and could finish the game without any kind of coughing or phlegming or hawking on the sidelines. And we actually knew when he relapsed for that because that cough came back. And so you see that chronic use, and so we have those difference between acute uses and our effects as well as the chronic use, to drop down. Don't forget, infertility is going to be one of the bigger conversations that we're going to talk to about women. Men, when we talk about infertility, it's a 30% reduction in sperm count. So if couples are trying to get pregnant, It's one of the things, if it's a challenge right now, we'll start talking to them about consumption of cannabis between her and her partner, if he's male. And if not, then infertility rates, especially for women, are starting to be affected. And this is for my physicians. These are medication interactions. So what we're finding is that when people go in to see their docs, and I have kind of a fun story that my partner shared with me, is they are starting to ask. Our medical providers are starting to ask. They're starting to ask in a better way, and they're still relatively kind of uninformed. The cutting edge physicians that know, they know, but the other physicians either kind of don't want to think about it, don't want to look about it, or don't know how to ask. And so these are just some medication interactions that we have that are common knowledge, and they're supported by research. So bleeding, blood sugar. So for diabetes, it's one of the best things to ask if they are using cannabis at all, because it's making most of the treatments ineffective. And then that drowsiness. And addiction, we know, like, it comes in a pair with a spare. And so that marijuana increasing drowsiness with benzos, narcotics, antidepressants, and alcohol, most of the time, especially when women use, they're not using in solidarity. They just don't step up and use cannabis. They're usually doing it in pairs. And so to know that there's medication interactions, even between drugs, is something that you can educate your clients or patients for. That was me taking a gulp. Sorry, y'all. So I know this is a heavy slide when we do it, but the Surgeon General's report gave us this this website, or a national study, and it happened just last year, and that was kind of a giggle for me, is that it was the first Surgeon General's report that was done on substance use for all of the topics that come up. Mostly because I'm biased and I would have loved to see it done 10 years ago and then repeat it again. But we know that right now there's a higher percentage of people, for those of us that are using cannabis, even more so than opiates, is that people that are using cannabis are doing so in a fashion that qualifies as dependence. And I say that because how they're using cannabis would actually qualify as a DSM criteria for moderate to severe substance use disorder. And that's at a much higher rate. It's like a 4.4% compared to a lower percent for opiates. And since we're right in the middle of an opiate epidemic, I'm usually like the quiet one in the corner going like, yeah, man, totally. And in the treatment field, we knew that pretty early on, that we were going to have a heck of a time with opiates and heroin as it started to come through our treatment centers. And so I often am the quiet one or annoying one at the end of the table going like, I completely appreciate that we're in that epidemic, and we've already started the next epidemic. And it's going to be cannabis, is that we're not going to know what to do or how to treat this, especially as the concentrates and potency goes up, and especially as we have more regular users and younger users for that. So all of these statistics are out there. We're going to talk about worsening prognosis for co-occurring. We're going to kind of go through and just talk about the commercialization. And that's the Hearts and Minds campaign that we're doing, is that last bullet point there, is when a state commercializes, and that's a nice way to say it, I say industrializes, is it changes our hearts and minds. And that's how this campaign is going for us, is that it's starting to lower the risk perception. We know that for monitoring for the future, is that as children start to be exposed, that's a perception of risk question that they've asked almost since the 70s, is what do you think is the risk is in using this drug? And as states have gone in through and legalized medical marijuana and then recreational marijuana, the perception of risk has dropped significantly. So when they talk about it for kids, we talk about it as, it's called a generational forgetting. And that means that I can't tell my kiddos a scary cannabis story unless I want to talk to them about a tourist jumping off a balcony, right? So we have a couple of them now, or a husband who murdered his wife based on cannabis use. But that would be why many kids that you see now, why Molly is kind of coming back, because many parents don't have a lot of stories to tell, scary stories to tell about hallucinogens. And so they'll make their way back after a generation because we've forgot. And that's where marijuana that we get to kind of tell those like dazed and confused doobie stories. And that's not the stories that are true right now. And so that part gets us into, so the states that have industrialized it, us, we have easier access, we're going to have heavier users, and we're going to have higher risk use of it as we start to go through. So on this one, I say yay to all the psychologists that got together and put it in the DSM. Thank you so much, because I get to go to my diagnostic statistic manual and tell my clients that they meet these criteria. It's sometimes a challenge, especially when we're talking cannabis, when we pull it out, to have these, to have them meet these criteria and not have it be about alcohol or opiates, because sometimes that interaction is that we know that cannabis might seem like the lesser of the evils when you get into the drugs of use. And I love that we have criteria and that we can start to put it and document it now in our charting, which hopefully is helping other physicians and other practitioners know that it's on board. And same for tobacco, is that I thanks Dr. Martin on that one. Like, I never leave a tobacco diagnosis off because of the interactions, and that leaving the brain open for cravings, it's an important part of their diagnostic impressions. On this one, I bring your attention. So even the Rooster and herb.com told me that women can get high faster than men. Very true. What science is also telling us, because of body composition, hormones, how we hold water, everything about women and our bodies, it actually makes withdrawal more significant for women. So you see the withdrawal symptoms that are there. And when a woman starts to stop or decrease her cannabis use, that these symptoms are much worse for women. I talk about it like a 16-day virus or a 4-day mystery illness, that with sobriety, time, and water, these symptoms can go away, amazingly enough. And that's the withdrawal. It's going to peak at 4 days. It can last us up to 16 days. And so you can still have, we call them the RIDS, to be restless, irritable, and discontent for up to more than 2 weeks, even if they're in inpatient treatment or an outpatient treatment, that an individual will continue to have that irritability, that nervousness, sleep, appetite changes, restlessness, and each of those is more significant for women as we start to withdraw. I tell you this, my side note is, what we know about relapse is if you have a higher tolerance to the substance and there's a tougher withdrawal. So if the withdrawal symptoms themselves are difficult, much like opiates, feels like, you know, gnashing of teeth and burning of flesh when you're coming off of them, it's a recipe for relapse. And so that's what we notice a lot for women, is because these symptoms are worse in women, we start to kind of gauge, is it worth it or not? Day 1, day 2, day 3, day 4. And by day 4, if it's worse for women than it is for men, and we still have a couple more days ahead of us, it usually encourages us to go back and use the substance in order to avoid feeling these feelings. So just know that that fact is not getting out as much, that withdrawal effects are worse for women, and they are. So these are the effects on the body, and this is, again, these are, as you can see, these articles are about 3 years old, and each of the studies that are coming out after them are still supporting a lot of these acute and chronic effects of use. And I'll tell you, the most up-to-date literature that we have, I love hate it, and you'll understand why when we get to it. But when we're looking for systematic, peer-reviewed publications, is we're coming up a little short. And so for us as a medical community, and even a treatment community, to say something as a fact, we often wait for really, really solid data and evidence. And right now, we are finding some mixed outcomes because the studies are poorly done, because this is a Scheduled 1 problem, as well as some of the funding that's coming through, is that we can't get a lot of the robust studies so that we could say definitely for a fact this is what's happening with cannabis. If you do your history lessons, tobacco had the same, air quotes, problem, which also left the industry open to exploit users for many, many years, until they started to produce facts. And even when they did produce facts and science, they were often watered down, refuted, and or the industry produced its own research, amazingly enough, that contradicted what the scientists were learning as well. But as I put this stuff up, these are the effects on the body. That slowed reaction time, motor coordination. This is what's starting to show up in our drugged driving, perceptual accuracy. They did a driving study where alcohol, people that were intoxicated on alcohol are actually more aggressive drivers. They'll go about 10 miles over the speed limit. And those that were high on cannabis actually slowed down. And so that's about 10 miles less. And I know some people are going, yay, slower drivers. However, if you start to get into driving behaviors, people that are going 10 miles lower than the speed limit actually cause accidents just as much. Some of the rates are just as high because people are then going around them because it's a behavior that they're not ready for. So just know that a slower driver on the road isn't necessarily a safer driver on the road. And that's one of the myths that we can debunk. It's going to hit us cardiovascular. It's going to hit our autonomic nervous system. And even for this, I bring up to the point a pretty risky aspect for pregnancy. For those of us that are actually doing trauma-informed treatment as well, this inability to modulate or to moderate our autonomic nervous system is also one of the ways that we're trying to, when we're getting sober and we're using our body as as a somatic kind of experience. If we are having trouble with temperature, it can actually exacerbate some of those trauma symptoms too, because our body doesn't feel like it is in sync with itself. So I've started to read a little bit of that. I'll throw some more data at you in a later study. Otherwise, for motor too, don't forget we're 2 times more likely for an auto accident when we are intoxicated with cannabis, and we're 9 times more likely for a bicycle accident because of all the other things that go into proprioception. More body stuff. Acute, we have those electrolyte imbalances, respiratory, our emergency visits are there, and that's what we're still seeing in Colorado is a significant increase in when people are coming to the emergency room, high, psychotic, not being able to handle the length of the high that was given because they weren't prepared for it. And all we get to do is treat it with time, water, and antipsychotics. So those are still the 3 modalities for treatment for that. You'll see it. So chronic use, we know that there's physical structure, there's structural difference in the brain, especially if you use before you're myelinated, immune systems, and reproductive difficulties. And I throw this in there because this is another one of those fun facts that's different for women. So because this drug is stored in fatty tissues, which we have more of, it will actually accumulate faster. And so that's some of the statistics when women are getting higher than men and we're staying higher than men, and also our tolerance is because of how this drug is stored in our body and because it takes longer to eliminate, is that we have more negative side effects of it being in our bodies for longer periods of time. I put 2 different charts up there because that's a little bit of what's coming out, especially if you're on the streets trying to figure out how to get a clean UA. Single use can be 3 to 5, sometimes up to 8 days. Frequent use up to 15, regular up to 30. And for heavy use, it's still taking about 63, 77 days to get out of our body. We actually have a woman who has a 2-day sobriety date, the day that she stopped using. And then she actually asked us to UA her as she went through, and she actually reset her sobriety date for the date that THC was completely out of her body. I give her major credit for that in and of itself. So mental health. So we did body. We know how it gets in our bodies. We know for women it stays in our bodies longer. We're building up tolerance for that, and it's taking us longer to get out of our bodies. And mental health is still the same. Memory, judgment, depression is higher, acute anxiety, which if you're having stress already and feeling overwhelmed, or trauma as well, this is not the drug to use because it actually can exacerbate the exact symptoms that you're having. Bipolar, and then suicide attempts are higher as well. And we know that the loss of up to 8 IQ points in adults, neonatal use, and so we'll kind of just really start to understand that this is what the science is telling us. I give you this one too because if you'll see the strength of association, if we use alcohol, we're in for cannabis. If we use tobacco, higher rates of cannabis use, social anxiety, panic disorder, and ADHD. um, it's there. So that's what the studies, these populations, that the co-occurring nature and the overlap, the comorbidity of these substances that they share with cannabis. And so if you get someone saying yes to alcohol use or tobacco use, that's your very next question, is to ask about cannabis use and what it does in their life. Psychosis, and then this is the point. So if you've zoned out by now, we know this one's on there, but if you zoned out by now, this is the science that lets us know what's happening directly for women. So we knew long, long ago in a land far away that this telescoping effect happened. And it happened more so when we could study it in relation to alcohol abuse. It was often my joke when I was in training and worked at the VA, and I said, "Do you ever see an old lady at the VA?" And I was like, "No, never. Why?" And I said, "Because she's not here." And that's what we're learning about substances. And we're starting to be able to universalize this to other substances as well. But when women we start using at a lower level. And that's not shocking. We're using it for mood regulation and stress reduction versus risk taking. So we usually don't that and drink the way a man would drink or use the way a man would use. However, our journey split after that. So when we continue to use, if that is going to be our drug of choice or if it's just going to be a drug that's around, and that's usually how women get started in use, is that if their partner uses or people in their social environment use, then we'll join in, usually for affiliation and connection. And we go harder. I'm getting head nods from the women. I know that out there in webinar land, because this is just a woman's brain. We're going to go usually harder, faster, stronger. Our tolerance is going to build up. Our bodies are going to start to store the substances, and we're going to need more to get that effect. We're going to chase that high, and we're going to have to do it harder and faster. Because of our body compositions, we're also going to incur the consequences of use a lot harder. So our bodies are going to absorb the consequence. So I say, if that's insomnia, if that's irritability, right? If that's starting to have liver issues, or even skin and hair, is that we're going to just look rougher. Our bodies are going to then kind of absorb the consequences of use harder. And science usually gives us kind of a 2-to-1 ratio. So for every drink that a man would drink, it's like I drank 2. And so the same is starting to play out in other substances as well. And for psychological differences, and this is what the science is showing us, is that women are going to use for mood regulation when we, instead of maybe reaching out for a psychologist or our primary care physician to start to treat mood, is we're going to use it for that instead, and stress reduction. We're really not in it for the risk taking as much. We'll leave that to men. So we even have a statistic like adult men are 2 to 3 more times likely to have a drug dependency or an addiction disorder. But women have a tendency to increase our rate of consumption of alcohol, opiates, marijuana, and cocaine more rapidly. We also need to realize this for relapse, is that when women relapse, it's going to be bigger, faster, harder, and stronger. So the interventions need to be faster. So I'll say that again. When and if we're going to use on a higher trajectory. And when and if we relapse, the relapse is going to be faster and harder. So that treatment needs to come sooner. And sometimes we can't wait around, especially for women and relapsing. This evidence is also starting to be true for heroin as we start to research it. Our women's issues, so when we talk about treatment, we're less likely to seek treatment. We have more barriers to treatment. Finances, because many times they are not our own. We are not in control of the finances, or they're shared finances through the family. Transportation, even a lot. Thank you, Holly. Here at DWR, we talk about executive functioning a lot. And for us, that means, can you figure out how to be empowered in your own world? If that's learning the bus system or taking Ubers or coordinating carpools to get to treatment, transportation alone leaves women out in the cold when it comes to treatment. Childcare and support for that, shame of just having a disease, having an addiction when maybe your male counterpart doesn't. And remember those tolerance levels and dependence levels, is that we are probably going to hold a higher level of a substance use disorder than our male counterparts for that reason. And then social support. So for a woman to go to treatment, how much more it takes for her to get there, to take care of the house, the family, even when treatment is offered, if it's offered during the day or only at night, that's a big deal. And so here we offer an early AM IOP as well as a late IOP, knowing that reason is that if you can get the kids off to school, or if you can get like the world organized, then you could probably have 3 hours in the early of the day, more so than in the evening time. And this is not a statistic, I wish it was, but we say it a lot in treatment team meetings. We call it the 90% rule. And so just anecdotally, what we learn is 90% of the time when a man comes to treatment, the woman will stay, support, be there, and actually sometimes even be engaged in treatment more so. 90% of the time when a woman comes to treatment, the man leaves. And that's what we have started to see. It's what we've known just anecdotally in the treatment field, is that when women stop to take care of themselves, it's usually an open door for a man to leave or to dissolve the union and kind of move on. We have some gaps. This is just a reminder for everybody, is when we say evidence and evidence-based studies, we are using the Controlled Substance Act as our guide. And so to be a medication or to be used in a medicinal way, it has to meet 5 parts. The drug's chemistry has to be known and reproducible. And so for cannabis, that's why we do not know what's in this plant and we cannot keep up with the potency. And one plant grown in Colorado is not the plant that's grown in Georgia. That's not the plant that's grown in Massachusetts. And so you'll start to see some of the conundrums for research. There have to be adequate safety studies, and they have to come from usually third party or unbiased. They have to be repeatable, and that's the reproducible part. There has to be adequate, well-controlled studies providing efficacy and not just guesses and not just people's stories. Although they're miraculous and although it's been used in so many ways to help and heal so many people, we have to have evidence. It also has to be accepted by qualified experts, and that does not mean scientists that are on the WARPEX payroll. And so it's got to be people within the academic field, people within the medical field, and the studies have to be widely available, everything. So you have to publish your studies, publish your results, and everybody's got to be aware of how the study was run. I just put this, again, not stubborn and not exaggerating. And so that's the part when we're on the streets talking and I become that teetotaler. I don't have to exaggerate. I don't have to make up stories because it is dangerous and cannabis is addictive. And I know that my population is small, but when we're using it for non-medical purposes, it takes a very, very, very sharp turn. So the medicinal uses that are getting reported to us are this relieving nausea, increasing appetites, the muscle spasms and spasticity. We don't have as much literature or support for chronic pain. That's actually getting there, and that's usually higher CBD, low to no THC. That's starting to help with pain. Intraocular, that's fancy. That's people that got the glaucoma. That one hasn't been proven at all. And then the relieving anxiety. Although PTSD and now our veterans are having access to it, anxiety reduction is not necessarily a repeatable effect of this drug. And that to me is a danger in and of itself when it's being marketed as such. This is what we're seeing mostly from anecdotal and then pro-cannabis kind of studies, a lot more about patients reporting what has helped with them. So in the general search, you will find that it helps all of these things. And before you saw my slide, that's all we have the evidence for. When we do a general search, it can do all of these things. And then these are the qualifying medical conditions here in the state of Colorado where you can get a red card for it. I'll stop. I think I have my time. I was asked a sensitive question by a supportive husband who his wife just went through cancer treatment, who kind of cornered me and said, you know, my wife's battling cancer. She uses a small amount of cannabis. What would you say to her? And I said, like, is she fully myelinated? Is she over 25? He said, yes. And I said, did she consult her doctors? And he said, yes. And I went, all right, I'll still talk. And I said, is she feeling better? He said, yes. And I said, has she stopped using cannabis? And he said, yes. And I said, okay, I'm not talking to you. And he looked at me and I said, she used a drug in a medicinal way that helped her get through a really, really intense treatment. I don't have much to say. And if even alcohol or other toxins are used that way, even if tobacco is used that way, I don't have much to say. But when our lives become unmanageable, I usually have a lot to say. I'm going to go through, and this is the women specific that we see. Marijuana is the most common illicit drug that's used in pregnancy. We have prevalence rates from 3% to 30%, if they're being accurate in some of the other studies. And that is in comparison to a 0.8% of women who use pain relievers during pregnancy. So that opiates, women are pretty scared, I think, to use opiates during pregnancy, but we'll go ahead and use cannabis for the reasons for nausea and or dependence. They will use it usually in the first trimester. You see a decrease or decline in the second and third trimester. Can't tell if that's because right now if the women are actually showing and maybe seeing a little bit more shame, or people are interacting with them differently if they see or use them smoking as the pregnancy starts to show. Some of our alcohol studies talk about that. And it's just different, and we know that. The anecdotal information that you hear a lot in women is that's actually the only period of sobriety that they've ever had is usually the 9 or 10 months that they have for pregnancy. And so if that's just white knuckling it or doing it for somebody else, women will usually battle their disease during those time periods and try to remain abstinent. This is a fact. It freely crosses the placenta. It's found in breast milk. It can start to accumulate to really high concentrations in breast milk. And so that's why when women are smoking, babies can actually get more of a concentration than the women are getting, because it will start to accumulate. It has adverse effects on development and can cause lots of problems with neurological development. In the most recent kind of catch-all health effects of cannabis and cannabinoids, this is a great book if you're willing to read. It's also a free PDF. That's how I like to read and use it as a reference guide. It's just come out this year. It lets the chapter that does prenatal, perinatal, and neonatal exposure. This is the fact that they can say with absolute certainty is that smoking during pregnancy is linked to low birth weights. And then the other outcomes are unclear. And I'm so sad to say that, because they actually had some really decent research studies, some systematic studies that let them know what was going on. Oh, I want to talk forever, so I'll just tell you stories from a dispensary. Bud tenders are about equivalent to a barista. I actually went the other day and told the story that I was 8 weeks pregnant, and I'm not. And he offered me a pretty high THC concentrate, even more above plant-based, and said, as a hindsight, of maybe you should talk to your doctor. So what I'm telling you is that the industry is loud and the medical community and counselors are quiet. And this won't help us. It'll put us into a stage of history as a resentful granddaughter whose grandfather was given tobacco as he was a soldier and became hooked and eventually died from those complications. I believe that this is where we're going to be at. What I can do for women is to focus on the family. And so I educate them as how to store their marijuana. If they are going to use, this is how to do it. And all of these rules for storage are on the Good to Know campaigns. I talk about accidental overdoses. I talk about what does child safety actually look like. I do talk to them about the universal symbol that we're using for THC. And now most, if not all, of the products have to have it on it, the edibles that come through. And so to teach kids that if you see that, it's kind of a Mr. Yuck generation. If you see that, do not eat it. We have the side effects for accidental marijuana use. Eating, drinking marijuana can make children and dogs very, very, very sick. So to keep them away from your beagles as well. A lot of consequences is that dogs' bodies cannot process the THC the way that ours can, and neither can children. So these are my mother must-knows. Know the consequences of using during pregnancy, and breastfeeding may not show up until your child is of school age. So just because you don't see something in the first couple months doesn't mean that the lasting effects aren't there by the time that they're 4 or 5, joining the school population. Cannabis is not recommended in any amount during breastfeeding, and a child who tests positive for THC can be reported to CPS. I use that one a lot. I will wait on my cannabis conversations. I have a great holiday hash story that I'll share later as we get off, but mostly these are my last 2 slides. If you have conversations and you're going for a harm reduction model, Know your expert. That means screening, brief intervention, and referral for treatment. We have evidence-based validated measures for screeners. Start to use them. It actually gets a number to what's going on. Give an abstinence challenge. If it's really not a problem, then ask them not to smoke for a while and or to decrease their potency or frequency. Get into an IOP treatment. If it's really not a problem and life isn't unmanageable, then educate yourself with the treatment. There is an evidence-based harm reduction curriculum that's out. It's from Germany. Talk about legal risks, talk about education, get people out there. As you know, for my abstinence model that I come from, know your criteria. As a clinician, that's the backbone of a conversation that you can have. Know the outcomes and the percentages for co-occurring problems. Know your medication interventions. Know the differences between youth versus adult risk. If you're fully myelinated, we have a different conversation. And if we keep smoking, we actually exacerbate cravings. So there's some literature that lets us know that for smoking as well as tobacco. Know all of the legal consequences and the ones that are germane to your state, and then challenge those reservations. As that, oh, it's just smoking, it's not a big deal, it's medicine. Have a conversation for that, and the wellness movement begins. Thanks. I probably talked through the question and answer, but I'll do my best.
Thank you, Dr. Bader. So I do have, I'm giving folks a chance while I ask a couple of questions to write in some questions that you may have in regards to the topic that she discussed over the last 45 minutes. I have a question in regards to your what you've seen in regards to insurance companies' response to marijuana addiction, and knowing in working in residential and now in outpatient, are you seeing any shifts or changes in third-party payers providing any kind of coverage for marijuana addiction?
Yes, actually at the inpatient level, what we do now that we have criteria for it in the DSM, the ICD-10, is that it's a diagnosis now. So it's not just a clinician's guess. And we can accurately identify post-acute withdrawal symptoms, which when we do those ASAM levels, that dimension 1 is usually where we're going to get our insurance coverage. And for cannabis, their symptoms actually last longer. And we can prove that they are actually still intoxicated while they're in treatment. That was actually one of my favorite URs to do, is that they said, I don't know why they need this level of care because they've already been there for a month. And I said, I just did a UA and got his nanograms per milliliter, and the gentleman is still intoxicated. Like he's still under the influence of the drug. And that is why this level of necessity is needed. And we've gotten hand over fist coverage at some of the inpatient places that I've worked, as well as outpatient, now that we have diagnostic criteria. That's why I use screeners, because I can get numbers and I can show you improvement in mood and mental health symptoms and withdrawal. So now I accurately, now that the DSM kind of tells me these exact symptoms that can often be used as other mood problems, is I can actually document pause a lot better.
So length of stay then is what specifically are you seeing for that in regards to coverage? I mean, if we know that it stays in the system sometimes as long as 60 days, obviously that's unrealistic to expect. Are they saying more on the, what they're seeing from the UAs as response to what the length of stay is, or how is it compromising their ability to be perceptive in doing cognitive work and treatment?
That's the part when we've had length of stay and it's been justified, is that literally they're psychotic. So a lot of the individuals that came in, even at like an inpatient level, is that they were experiencing thought disorder, and they were unable to work, function. Their social impairment was still really high. And so time, water, electrolytes, and antipsychotics are the modality of treatment right now. And that makes it a pretty severe withdrawal, and it makes it a pretty severe treatment episode. Sometimes you honestly didn't get to meet a patient for about 30 or 60 days until they would literally then start to participate in group. So we talk about that minimal participation in group, difficulties with cognition and thought. We can also use psychological testing to show the impairment levels that are there, and that's helping us get some more criteria to work with insurance.
That's great. So Susan has asked, what medications are being used for cravings and withdrawal symptoms?
So withdrawal, what we have, so far, what our addiction psychiatrists are brilliant about is that we're sometimes using antipsychotics, because if we're having those kind of symptoms that are being used, they'll try to treat all of the symptoms that you see in the withdrawal. So if there's irritability and mood, we'll come in with some mood stabilizers, right? Some SSRIs to try to help with the anxiety or the irritability. They'll treat some of the sleep symptoms, right, with your trazodones or other kind of medications. They'll use a gabapentin every now and then. And so that's where kind of the art and science for cannabis withdrawal is being treated. So we're trying to treat the symptoms as they go through post-acute withdrawal. And then we have the anti-craving medications that we'll use. But so far, this is like what we're noticing, especially with the CB1 receptors and getting to know the brain, there's not a medication, like there's not an Antabuse, and there's not a Vivitrol. There's not an naloxone yet, or naltrexone, naloxone, sorry, one of those days. We don't have a medication specifically used for medication-assisted therapy for cannabis yet. And so what we're trying to do, what addiction psychiatrists are trying to do, is to treat the symptoms to where the person can be comfortable enough to start their step work and to start their treatment, and then continue to do relapse prevention through behavioral skills. And if they can use a medication-assisted therapy, to do so, but there's nothing really specific for cannabis that I know of yet. And that might be out of the scope of my practice. So I'll get you in touch with some really great addiction psychiatrists that I know.
Wonderful. That's great. There was a question asked by Lydia if the slides would be made available. We are going to make this recording available, and if folks are interested in having access to the slides, is it okay for them to email you directly?
Absolutely, because I would love to have a continued conversation with them.
Can you provide your email address?
Sure. My name it's L for Letitia, L Bader at denverwomensrecovery.com.
And if folks aren't able to get that down, you can always email me. You have my email address, and we'll be happy to get that information over to you. At this time, I think we're pretty set on questions. I want to thank you, Dr. Bader, again for taking the time, and also to thank Denver Women's Recovery. Oh, we've got a couple of other things coming up. So Ben Cord, of course, is on. Says, fantastic presentation, Dr. Bader. Thank you. Some new stuff, which is hard to believe for Ben, because it seems like he's so...
I'm plugging his book, Weed Inc. Go out and buy it. It's one of the best conversation weed books out there. If you're trying to discuss this topic with a 17-year-old or a really sassy 45-year-old, it's the best book that I've used. Thanks, Ben.
And then Parker is asking, you mentioned gabapentin as a withdrawal treatment for cannabis. Recently, more and more data about gabapentin's habit-forming nature. Is it still Is it more harmful than good to prescribe gabapentin for cannabis, or is the cannabis worse?
So that's where I start to, that's out of the scope of my practice. So I know when we're using those medications, it is in very early recovery. It is not used, it's used in an acute setting for what the body is going through right then. And that's a withdrawal medication to just make a patient more comfortable. And that's what sometimes that we do in post-acute withdrawal when it's really acute. Remember what I said, is like, we're going to return to use if the withdrawal is worse than I can tolerate. And so that's when medications are being used. They're being used in a really short-term period of time to try to get the body, brain, soul, spirit through that moment. Responsible use of habit-forming medications, or that's why I always have an addiction psychiatrist on our team. We have Dr. Lofton's on our team. I love her for that, because those are not long-term medications that are used. We try to use them in the short term to get an individual through that discomfort, that uncomfortable period, so that they can start to enjoy the parts of recovery and sobriety that come with it. So Parker, this is mine, like, shout out and go to a local addiction psychiatrist and get the lowdown of what they do, because that's kind of the art and science of the drug of use, the withdrawal for that individual. And then, like I said, it's the individual's experience of that withdrawal, that medications are used and for a short period of time, and then try to wean them off of that so that they can have a period of sobriety. That was a little roundabout, and I hope that makes sense.
It does. Thank you so much. And I'm sure we can continue this conversation much longer, but We want to thank you again for your time, and thank you to Denver Women's Recovery. For those of you that are listening, you will receive your certificates of completion by Friday. If you don't receive it, please give me a call or email me at gthorn@harmonyfoundationinc.com. Happy holidays to everyone, and we'll see you next year.